Good morning, students. So today we'll be taking the some of the previous year questions which have been asked in the last year papers, that is in the AIPG as well as in the NEET exams, and also in the other exam papers like AIPG or the PGI Chandigarh exams. Now, I have already gone through this questions series, and I must hope that you also have gone through the PDF file which I think Amit Lal sir has shared with you. Now, in this series, we'll be discussing each question one by one. And if you have any doubt related to this question, you can ask me in the chat box immediately. Okay. So the first question that has been asked is related to the Ellis class 5 fracture. Okay. Now in this question they have asked that what is the Ellis 5 class fracture. Am I audible now? So this Ellis class 5 fracture is basically defined as the teeth lost as a result of trauma. Okay, so it is defined as the tooth that is lost as a result of trauma. Now the other terms that are basically used for the Ellis class 5 fracture is either avulsion or X articulation. Okay, so these are some of the other terminologies that are used for a class 5 fracture. Now, the next question is, a 13-year-old male with a history of trauma and discoloration of the upper incisor comes to you. What is the class of fracture according to the Ellis and Davy classification? Now, if you can see in this diagram, the teeth has become discolored. Now, the discoloration is basically a sign of that the tooth has become a non-vital. Okay, there is no blood circulation, and the age of the patient is 13-year-old. Okay, so in this case, they are asking that what under what Ellis and Davis classification it comes. So it comes under the class 4, which is generally said to is the tooth becomes non-vital as a result of trauma. So the class 4 is the tooth becomes non-vital as a result of trauma. Now moving on to the next question, where they are asking you that an 8-year-old patient reports to the clinic immediately after the traumatic injury to the maxillary incisor. What is the diagnosis and the management of this case? Now, if you see that the age of the patient is 8-year-old, okay, the tooth involved is the maxillary incisor. So I have told you in the lecture also that whenever you are getting the cases related to the traumatology or related to the pediatric endodontics, 99% times you will be getting a clinical question. Very rarely they'll give you a direct question. Now, if you see in this, the age of the patient is 8 years and the tooth involved is maxillary incisor, and we know that the root formation of the maxillary incisor completes by the age of 3 years. Okay, now in this case they are asking you, sorry, the root of the maxillary incisor completes by the age of 10 years. Now in this case they are asking you that what will be the diagnosis and the management. Now if you see, we can see the teeth that is fracture and we can see the exposure of the pulpal tissue. Okay, so if there is an exposure of the pulpal tissue, so according to the Ellis and Davis classification, we say that the fracture that is involving enamel, dentine and pulp comes under Ellis class 3 fracture, comes under Ellis class 3 fracture. And what will be the management? Now I have told you that in this case the root formation will be incompleted because the root formation of the central incisor completes by the age of 10 years. So in this case we need to do a procedure, and that is basically called as Schweck's pulpotomy. Okay, that is called as Schweck's pulpotomy, that leads to an apexogenesis. Now if you see the options that they have given in the MCQ is, they have written as like pulpectomy, direct pulp capping with MTA, or direct pulp capping with calcium hydroxide. But on the other hand, if you see, they have written class 2 fracture, class 2 fracture, class 3 fracture. Okay, but in the class 3 fracture they've used the word pulpectomy. So we know that it's a class 3 fracture, but which will be the best option that will be going is a direct pulp capping. Okay, now here why we are doing the direct pulp capping or we are doing a Schweck's pulpotomy, that is we are removing the partial removal of the coronal pulp so that we are not disturbing the Herdwig epithelial root sheath cells and the root formation take place on its own, and that leads to apexogenesis, that leads to apexogenesis. So the best option in this question that is going with is direct pulp capping. Okay, that is with Ellis class 3 fracture. Next question, again a 8-year-old male reports with a Ellis class 2 fracture. Now what is Ellis class 2 fracture? A fracture involving enamel and dentine, and the tooth involved is maxillary central incisor. So on examination the tooth seems to be fine and there is no pathologic finding. How you will restore the tooth? The option that are given is GIC restoration, acid H plus composite restoration, conventional gold, and the full coverage restoration. Now in the lecture I have told you that whenever we have a patient with a Ellis class 2 fracture, the first and the foremost thing that we'll be doing is that we will be covering the dentinal tubules with a sedative dressing followed by a composite restoration. So in this case, the best option that is going with this condition of Ellis class 2 fracture is acid H plus composite restoration. Now the next question is, the classic picture of the dog and bell experiment is representative of which theory? The operant conditioning theory, which was given by Skinner, the social learning theory, which was given by Albert Bandura, then there is a servo system theory, and the classical conditioning theory. So we remember that we have studied this dog bell experiment in the classical conditioning theory by Pavlov, okay, where we have learned that the uh, where we have seen that the bell that was used was basically a uh, neutral stimulus, but later on it has become a conditioned stimulus, okay, and the dog started giving a response, and that response is called as a conditioned response. So the treatment that was suggested by Pavlov was counter conditioning, where we have told that you change the conditioned stimulus to get a change in the conditioned response, okay. Now the next question is, the orthodontic appliance that has coil in the anterior and the posterior region used for the correction of posterior crossbite. Option A is Nitai expander, then B is the W arch, C is quad helix, and the D is two anterior and posterior helix. So according to you, which will be the correct answer? So you must all have seen that in the NITA expander we basically use the expansion thing. Okay, we expand the arch. Whereas in the W arch, if you have remember, I have told you in the lecture also, the design look like this. So this is W arch. Okay, whereas the quad helix is, so this is how the quad helix looks. Now this is called as the W arch or Porter appliance, and this is called as quad helix, which is used for the correction of posterior crossbite. Now the next question is, identify the A, B and C in the preventive resin restoration. Now what is preventive resin restoration? I have told you that it's a combination of pit and fissure sealant plus restoration. So if you see in this diagram, the A basically is a sealant layer. Now this is a sealant. Then the second layer is the restoration, and the third layer is basically a base. Okay, so if you remember, I have told you regarding the pit and fissure sealants and also regarding the preventive resin restoration. So this preventive resin restoration was given by Simonson and Stillord, and they have divided according to the depth of the lesion, that is the depth of the cavity generally we see, and we have divided into type A, type B and type C. Type A where the caries is confined to the enamel, type B where the caries has extended to the dentine, and the type C it is called as a deeply carious lesion. So in this case we can see that it's a type of type C. Now the next question is a case with a deep pit and fissures with enamel decalcification and caries confined within the enamel in the distal aspect of the fissure. The choice of restoration is sealant, B composite, C preventive resin restoration, and D is atraumatic restorative technique. Now if you see in this question they are telling that there is a case with a deep pits and fissures. Now this deep pits and fissures is seen in a newly erupted teeth. Okay, there is slight enamel decalcification and caries. Now here they have told that this caries is only confined to the enamel. Okay, so this means that it is type A of preventive resin restoration. So we'll just excavate the caries that is confined within the enamel, cover it with a restoration, followed by the addition of the sealant. Now the next question is question number 189, that is identify the appliance. You can see a V-shape extension. Okay, so this is basically a V-shape extension appliance, or that is basically given especially when there is a exfoliation of primary second molar before the eruption of first molar. Okay, so here a V-shaped notch or an extension is given, that is basically guiding the unerupted first molar, first permanent molar. Okay, so it is acting as a guiding appliance. So distal shoe is also called as eruption guiding appliance or a intra-alveolar appliance. Now the next question they are asking that what is the new addition in the modified pedodontic triangle. So this pedodontic triangle was given by GZ Wright, and the child is at the apex of the triangle, and the dentist and the parent are on the either side of the triangle. Now the fourth component that has been added to this pedodontic triangle was society. Okay, now the fourth component that has been added to this periodontic triangle is the society. See, one student is asking the bilateral loss of the primary second molar. Okay. Now the bilateral loss of the primary second molar depending upon what age of the patient is. If the age of the patient is suppose less than 6 years and the first permanent molar is unerupted, then definitely you can go for a bilateral distal shoe. Okay. Or if the age of the patient has exceeded greater than 6 years, or we see that the first molar is partially erupted, okay, the first permanent molar is partially erupted, so you can go with a reverse band and loop. And if the first permanent molar is fully erupted, then you can go with a normal band and loop space maintainer. Or if the incisors have also erupted, then you can go with a lingual arch also. The most common is basically the flush terminal plane. Now the next question is, a child of 6 years of age present with a generalized spacing of the upper dentition with a lower permanent incisor erupting, what treatment you will do? Now this generalized spacing is considered to be a physiological space and it is considered to be a normal. So in this case we will not do any treatment, and in a case of a primary dentition, the physiological spaces, if they are present, they are considered to be a ideal dentition. So we will not do any treatment, just wait and watch. Now, in case of the loss of the mandibular primary molar, the soldered lingual arch commonly given, what kind of space maintainer is it? Now, in this case, they are asking you to classify the space maintainer. So, the lingual arch in this case is classified as fixed, non-functional, bilateral space maintainer. Non-functional means that it doesn't aids in mastication. Now the next question is, the primary mandibular first molar is missing bilaterally in the mixed dentition. The space maintainer of choice is. Now they have given the options like distal shoe, Nance, band and loop and lingual arch. Now see, the term used is mandibular. So the Nance is basically used for the maxillary arch. Okay. Another important thing that is basically a mistake that I can say in this question is that they have not mentioned the age. Okay, they have not mentioned the age. So if the age would have mentioned, then definitely the options can be a banded loop also. Okay, but they have not mentioned the age. So the in this case right now the current answer is lingual arch. See, wait and watch options are they have given is that they have told that there is a physiological spaces or the generalized spacing is present. Okay. Now, the physiological spaces or the generalized spacing are the ideal thing. Okay, it's a self-correcting anomaly that is present in a primary dentition. So in that case, no treatment need to be done. And I have told you this in the chapter of the development of occlusion, where we talked about the physiological spaces, the primate spaces, and we talked about the first transitional period, the inter-transitional period, as well as the second transitional period. Okay, and I have told you about the early mesial shift and also the late mesial shift. So remember, these are some of the things that are considered to be self-correcting. They get corrected on its own, so nothing treatment to be done. Now, mother of a 3-month-old child reports with a complaint of the ulceration of the underside of the tongue, due to which the child is not able to take the milk. The ulceration is because of the repeated back and forth movement of the tongue over the erupted incisor. Now, this condition is called as Now, the ulceration that is present on the ventral surface of the tongue is mostly seen when during the presence of the natal or the neonatal teeth, and this ulceration that is caused by the natal or the neonatal neonatal teeth on the ventral surface of the tongue is basically called as a Riga Feda disease. Okay. Leishman syndrome is a disease where, or a syndrome where the patient basically cause the self-injurious, you can say, damage to himself or herself by lip biting, nail biting, or gingival stripping. So it's a self-injurious habit. Okay, so you will see a self-injurious habit in the Leishman syndrome, but Riga Feda disease is where you see the ulceration on the ventral surface of the tongue because of the presence of natal or a neonatal teeth. Now, during cavity preparation in a primary mandibular first molar, a pinpoint pulpal exposure occurs. What you will do? Now, there is a pinpoint pulpal exposure is taking place. Now, they have given the options like in pulpectomy, indirect pulp capping using calcium hydroxide, direct pulp capping using MTA, direct restoration using composite. Now I have told you that generally direct pulp therapy, that is DPT, is contraindicated in the primary teeth. The reason is that the spread of infection is very fast. Okay. Now if you see the previous MCQs that were asked in the AIPG papers, now there they were using the term that is pulp capping or direct pulp capping for the procedure such as pulpotomy. Okay, so in this case the option that is going is direct pulp capping using MTA, and that is basically the pulpotomy with MTA. Okay, so in the earlier days what they were doing in the MCQ is the terminologies that they are using for the pulpotomy is basically a direct pulp capping. Now a child shows an ankylosed primary molar with a successor permanent tooth bud developing under its roots. What will you advise the parents? Extraction of the primary tooth immediately? No, will not extract because there will be a space loss. Then extraction of the primary tooth when it starts to causes the alteration in the path of the eruption of the successor? Yes. That is will be the correct option because we'll extract only if it is causing the hindrance in the path of the eruption of the permanent tooth bud. Retain the primary tooth and extract it when it start interfering with the eruption? No. Retain the primary tooth and extract the successor in surgically? No. So the best option is B. Now next question is a baby with a multiple ulcers, fevers, unable to eat and cry. What he is suffering from? Now if you see there are a lot of vesicle formations that are seen onto the dorsal as well as the ventral surface of the tongues, and these vesicles generally get bursted. Okay, and this type of characteristic feature is generally seen in the kids of age group less than 6 year old. Okay, and this condition is especially seen in the cases of a primary herpetic gingivostomatitis. Okay, that is mainly caused by the herpes simplex virus 1. Okay, and not only this, you can say the ulceration that you're seeing on the ventral or the dorsal surface of the tongue, it also involves the lip, the cheeks. Okay, and you'll see the bleeding from the gingival tissue, you will see the inflamed gingival tissue. So that is mainly seen in the herpes simplex virus 1. Okay, and these are the case of acute herpetic gingival stomatitis. Now, patient with no perioral muscular coordination is seen in which type of cerebral palsy? Now, we have discussed this in the notes. And we have discussed the cerebral palsy that there are three types, that is spasticity, atheosis, ataxia, and the last one is the mix. And I have told you that the poor involuntary control over the, you can say, the muscular coordination is mainly seen in the spasticity type of the cerebral palsy. So the answer for this question is spasticity type of the cerebral palsy. Now, the next question is, a 7-year-old patient reports to the clinic with pain and swelling in the lower right back region of the jaw. The IOP is attached to a reference. The most appropriate treatment would be. Now, the age of the patient is 7 year old. Okay, so we know that the tooth involved is the mandibular primary first molar, and there is a pulpal involvement. Okay, there is a pain, there is swelling. So in this case, the best option is that we know that the teeth will erupt by the age of 10 to 11, that is the premolar. So till that meantime, we need to retain the teeth as a space maintainer. So the best option is, since the patient is having pain, so we'll go with pulpectomy followed by stainless steel crown. So the answer is pulpectomy and stainless steel crown. See, in the spasticity, you will see a poor muscular coordination, whereas the uh, in the atheosis, okay, you will see the slow voluntary control over the muscles. Okay, a parent brought her 2-year-old child since she was unable to eat since the past 3 days. So the age of the patient is 2 years old. The child presented with an elevated temperature and was continuously crying. The image of the doctor assessment is attached for your reference. What is the diagnosis? Now, if you can see, again, you can see the ulceration and the vesicle formations that are present on the lip as well as on the cheek area. Okay, and just now we have discussed that these are the classical sign of the herpes simplex virus leading to the acute herpetic gingival stomatitis. Now, sometimes when we treat the this primary herpetic gingival stomatitis with the help of the drugs like acyclovir, and we give a lot of multivitamins, we seen that sometimes it get corrected, but in the later part of the age, we generally see the recurrence of this primary herpetic gingivitis with the formation of the ulcerations on the lip and the cheek area. But in this case, the signs are little bit on the acute side, and you are seeing this at the age of 2 years. So the option that is primary herpetic gingivostomatitis. Frank cavitation is seen in the dentine. According to the American Dental Association, the corresponding uh, uh, grading should be initial caries, mild caries, moderate caries, and severe caries. So, answer is severe caries. So, we have attached the chart for this also. Okay, just go through this chart. Okay, which is sound, initial, moderate, advanced is basically the severe form. Okay. Now, one student is asking that in the question number 193, if the age is not mentioned, that why not band and loop and why lingual arch? See, in that they have only mentioned regarding it's a mixed dentition. So, on the basis of that, we have written lingual arch. Okay, that is why we have not gone for the band and loop. Then one student is asking that if exposure is less than 0.5 or iatrogenic, then to do DPC. See, if there is an exposure in the primary molar, then definitely we are not going for the direct pulse therapy. I have told you that these terminologies, that is direct pulse capping, they generally use for pulpotomy. And if you see the older textbook of the MCQs or the older AIPG questions, there you find instead of pulpotomy, they are using a word direct pulse capping. Okay, but I have told you that this direct pulse therapy is contraindicated in the primary teeth. So in the cerebral palsy, I have told you that in the spasticity we have the involuntary, you can say, muscular coordination, and that is a poor involuntary muscular coordination. Whereas in the case of the ichthyosis, we have a slow involuntary muscular coordination, and in the ataxia we have a better compared to the compared to the compared to the spasticity and the ichthyosis. Material of choice for the pulpectomy for the primary teeth is definitely a calcium hydroxide and the iodoform based material, as well as if you have the endofloss, then definitely that is. But in the options they have not are not mentioning the endofloss, so we will be going with either metapex or vitapex. Now coming to the question number 172. Now this kind of behavior comes under which type of the theory of learning? So here you can see that the one child is basically sitting on the dental chair, whereas the other child is standing along the dental chair and just observing the child. And the other picture, you can say that the child is seeing a picture on the monitor related to the treatment of the uh, child. Now this is something called as a modeling technique, where the model can be a live model. So this is a live model and this is a film model. Okay, and this was given by Bandura, and that theory name is the social learning theory, that was given by Bandura. So this modeling, okay, was given by Bandura, that is acquisition of behavior versus performance of behavior. Now, in the following condition, which kind of space maintainer will you use in? Now, if you can see in this case, the one central incisor has already erupted, and the other central incisor, you can see the bulge that is almost about to erupt. So, in this case, there is no requirement of any space maintainer because it's an interior teeth which are missing, and I have told you that we rarely use the space maintainer for the anterior teeth. We basically use for the posterior teeth mainly, and the only space maintainer, the fixed space maintainer that I have told you for the anterior teeth, is the pin and tube space maintainer. Okay, so in this such conditions we don't go for the space maintainers, so no space maintainer is required. Now, as per the IGDAS, that is the International Caries Detection Association System classification, the early cavitation lesion involving less than half of the tooth structure with frank dentinal involvement is classified as mild, moderate, advanced, or initial. So, uh, if you go through the chart of the IGDAS, definitely you will find that if the lesion is involving the dentine, then definitely it comes under the advanced type of the lesion. Okay, in which condition the pulpotomy is contraindicated in children? Okay, So, especially pulpotomy is contraindicated in the patients who are having a leukemia. That is something related to the blood cancer, and definitely we will not do any blood borne procedures in this type of patients. So, definitely pulpotomy is contraindicated in the children who are having a leukemia. Now, question number 176. A 5-year-old child patient has lost both the mandibular first primary molar. Which appliance is indicated? Now, the age of the patient is 5-year-old and the tooth involved is mandible. So, we need to talk about the space maintainer that are used in the mandibular teeth. Nance is used in the upper arch. Lingual arch is used again in the mandibular teeth. Then we have a lingual arch modification with canine spurs. And the third is the bilateral band and loop. But if you see the age of the patient is 5-year old, so the age of the at the age of 5 years, the centrals and the laterals, permanent centrals and laterals have not erupted. And I have told you that the lingual arch is only given when the permanent incisors are present. So in this case, we will not be giving a lingual arch, we will be giving a bilateral band and loop. And that is why in the lecture also I have mentioned this in my indications of the band and loop, when the primary incisors are present, and in the lingual arch I mentioned when the permanent incisors are present, that is the permanent centrals and the permanent lateral, because in the lingual arch the arm rests onto the cingulum of the incisor, or 1 to 1.5 mm above the gingival margin. Now, what is the use of the calcium hydroxide in the case of the pulp therapy? Now, it caused the numbing of pulp? No. It caused the surface fixation by killing the odontoblast? No. It causes the release of the calcium hydroxide ions due to acidic pH? No. It causes the stimulation of the fibroblast from the pulp tissue? Yes. Basically, pulp is a mesenchymal tissue, so pulp has a fibroblast cells. So once we place the calcium hydroxide, the first layer that is formed is the zone of necrosis, then is the zone of atrophy, and the third is the zone of inflammation. Okay, so in the case of the pulpotomy, when we are using the fixative agent, the first zone is formed is the zone of fixation. Now in the case of the calcium hydroxide, there will be a differentiation of these pulpal cells, that is the mesenchymal cells, into the odontoblast cells and the odontoclast cells. Okay, so it never caused the surface fixation, it caused the necrosis. No, extraction is not done in leukemia. Now, in this question, they are asking that the child with a moderate to severe intellectual deficiency, which technique will the dentist employ? Now, this I have told you in the lecture also. There is a IQ classification by Stanford Binet, where I have told you from the intelligent to the you can say the childs who are having intellectual disability, where the IQ is less than 69. So if the IQ is less than 69 and they are asking you the classification related to the IQ of the kids who are less than 69, so in that they are asking that the kids who are moderate to severe. Okay, now if you remember in the lecture I have told you the classification of the IQ, that is intelligent question, and we start from the uh, you can say intelligent, very intelligent, average, then borderline impaired, and then so on. And in the last we say that the IQ is if less than 69, then the child has a intellectual disability. Now the kids who are having the IQ less than 69 are further classified by the mental association deficiency uh, organization, and they have further classified this into mild, moderate, severe and profound. Okay, now they are asking that the kids who have a moderate to severe. Okay, now in this case you can see that if the child is already having IQ less than 69, Then will you go with a non-pharmacological behavior management technique? No, I'll not go with a non-pharmacological. I'll definitely go with a pharmacological behavior management technique. So in this case, if you see that they have mentioned mild sedation, whereas the other technique like tell show do, hand over mouth and modeling are the non-pharmacological behavior management technique. So the correct option is a pharmacological behavior management technique, and that is mild sedation. And the kids in the categorization of the mental deficiency classification from moderate to severe are the kids who are trainable or have a limited trainability. Okay, so these kids need to be treated under the pharmacological means rather than under a non-pharmacological means. Now, technique of placing the crown without removing the caries and without crown preparation in a primary tooth. Now, I have told you about this technique, and that is called as a Hall technique. Okay. Now, I have told you that Hall technique is where we place the crown as such, and where we don't remove the caries, because we cut down the supply of nutrients to the microorganism. So the caries get arrested on its own. So this technique is called as a Hall's technique. Now, a 7-year-old child reported after 2 days with a trauma to 2-1. 2-1 is basically a central incisor, and the age is 7 year old. Okay, and he reported after 2 days, that is 48 hours, with pulp exposure. On examination, the tooth shown signs of vitality. What will be the best treatment? Now, the patient is reporting within a period of for 72 hours. Okay, within a period of 72 hours. So, and the root formation of the central incisor is incomplete because it forms by the age of 10. So, I'll be preferring to go with a Schweppes pulpotomy. Now, the best option that is given in this answer is yes. The correct option is apexogenesis, because I know that the Schweppes pulpotomy will lead to apexogenesis, where we do a partial removal of the coronal pulp without disturbing the Herdwick epithelial root sheath cells, which are responsible for the closure of apex. A 5-year-old patient present with a root stump of tooth 7-5, which is painful. What is the treatment? Now, if the tooth stump is present, that is 7-5, age of the patient is 5 years, that means the first permanent molar is unerupted. Okay, so the best treatment is that I should extract the teeth followed by a distal shoe space maintainer. Now, nitrous oxide cause diffusion hypoxia because now, what is diffusion hypoxia? Now, whenever we give a nitrous oxide to the patient, what will happen is that it disturbs the normal inhalational and the exhalation process. So, when we are giving the nitrous oxide to the patients, these nitrous oxide get enter into the alveoli of the lung. So, it is always said that once you are completed with the dental procedure, at the end of the procedure, you flush the oxygen for 5 minutes. The purpose of flushing the oxygen for 5 minutes is to eliminate the nitrous oxide from the alveoli of the lungs. So if you will not eliminate the nitrous oxide from the alveoli of the lung, the patient may end up into a withdrawal hypoxia or a diffusion hypoxia. Okay, and that is because of the presence of the nitrous oxide in the alveoli of the lung. So it is always important that when you complete the procedure, you just flush the nitrous oxide for you just flush the oxygen for 5 minutes at the end of the procedure. So the correct answer is that diffusion hypoxia occurs because of the movement of the nitrous oxide into the alveoli of the lungs. See, sevoflurane is generally considered to be the safest form of the anesthesia, especially when we are doing the general anesthesia. Okay, but definitely it's an expensive thing, and and if you consider on the safety point of view, nothing better than safe than sevoflurane. A medically compromised child needs tooth extraction. The prophylactic antibiotic should be given 1 day before the procedure, 1 hour before the procedure, uh, not needed after procedure. Now, according to the American Academy of Pediatric Dentistry, the guidelines have been given that if you are doing the prophylactic antibiotics to a medically compromised child, then definitely it should be given, they say generally 60 minutes before the procedure. Okay, so that is 1 hour before the procedure. So the correct answer is B. Now, a 7-year-old boy has a crowding in the erupted 31324142 arch. Analysis reveals arch length tooth material discrepancy and tendency for crowding. What should the dentist do? Initiate the fixed orthodontic treatment after all the permanent teeth erupt. Review in 6 months. Initiate the serial extraction followed by space maintainer. Distalization of the permanent molar. See, generally in this case, definitely we are seeing that there is a crowding in the lower anterior segment, and we have checked out that it's a truth material arch length discrepancy. So we'll plan for a serial extraction, but you know that the serial extraction is generally done after the age of 8 years. So that is why they are saying that review in 6 months. So the correct answer is B, that is after 6 months. Now this is a chart that I have downloaded for you, the antibiotic prophylaxis. So if you see this chart, where they mention the antibiotic regimens for a dental procedure regimen: single dose 30 to 60 minutes before the procedure, oral we are giving amoxicillin, okay, 2 gram in adults and 50 milligram per kg in children. If those who are unable to take the oral medication, then we can go for intramuscular or the IV solutions also. Now, during a forensic evaluation of a subject, an investigator uses a method of age determination in which 7 teeth left lower quadrant are examined. Which method of age determination is the examiner using? Now, there are different methods like Gustafsson method, Scour and Messler method, Demerjen method, and Kohler method. Now, in the Gustafsson method, we basically use the ground sections of the teeth, whereas in the Scour and the Messler method, basically we are studying not only on the permanent, we are studying the primary teeth also. Okay, but in the Demerjen method we are studying the 7 teeth in the mandible from the incisor to the second molar. Okay, and we are just checking the calcification pattern of that, okay, whether it is clinically or radiographically. So that method, that in this the question they are asking, is basically a Demerjen method. Okay, and Kohler method is basically used, Kohler method is basically used especially with the you can say by studying the you can say the eruption or the calcification of the third molar. Okay, so in the Kohler method we basically study on the third molar. Now, according to the Stanford Binet classification of the IQ, 90 to 109 is classified as average, very intelligent, moderate, intelligent, genius. It is average. Now, in a child with a rampant caries and a white spot lesion, which is the best topical fluoride to be applied? The best topical fluoride to be applied is the APF, that is the acylated phosphate fluoride. Why we are not saying the sodium fluoride? The reason is that we know regarding the sodium fluoride that there is a choking effect phenomenon, so the reapplication doesn't works better. And in the APF, the penetration of the fluoride will be much better, and that helps in the remineralization process. Okay, so that is why in the rampant caries or in the early childhood caries, the fluoride that we generally prefer is APF solution. Now the next question is identify the type of injury according to the Ellis classification. You can see the exposure of the pulp. So the fracture involving enamel, dentine and pulp is Ellis class 3. Now again a question related to the fluoride, and just now I have discussed that a repeated application of the sodium fluoride leads to a choking effect phenomenon. Okay, and that is because of the formation of a layer that is called as calcium fluoride that prevents the further penetration of fluoride. A 5-year-old child is behaving badly in the dental clinic and is not cooperative. In response to, the caregiver takes away his favorite toy and insists the toy will return only after the child allows to do the dental procedure. This type of behavior management technique is called as omission, positive reinforcement, negative reinforcement, or punishment. Now, if you remember the theory, that is the operant conditioning theory by Skinner, where I have told you it's four stages, sorry, where the first is positive, second is negative, the third is omission, and the last is punishment. In the omission, I have told you that the withdrawal of a pleasant stimulus to decrease the probability of the behavior. So the pleasant stimulus is that we ask the kid to get his favorite toy or any gift or anything that he likes the most. So if the child doesn't cooperate in the dental treatment, so we take the toy from the child and tell that unless and until you get a dental treatment done nicely, then only we'll return your toy back. So that is called as omission. Now technique for altering the child behavior so as the to get the desired behavior by the dentist and his team in clinic is called as positive reinforcement, behavior shaping, contingency and desensitization. Now, I have told you regarding the difference between the behavior management and the behavior shaping. If you remember in the starting lecture of the non pharmacological behavior management, where I have told you that behavior management is basically a teamwork, and behavior shaping is that we shape the behavior of a child and we do the treatment in a you can say consecutive appointments or settings, so that the desired behavior which I required during the dental procedure, that is regarding giving a local anesthesia during a pulpectomy or extraction, the, the desired behavior which I want I can achieve during that time. So that is basically called as a behavior shaping. Okay. See, SNF mostly we are avoiding it because of its taste. The kids generally doesn't like the taste of the stainless fluoride, and it generally causes a little bit of discoloration also. Okay, so to the restorations, so that is why we are avoiding the use of stainless fluoride. But I am discussing the other options also. Okay. Now, coming on to the next question, a 6-year-old child. The child is very anxious when brought to the dental clinic. He doesn't obey commands, shouts, and becomes hysterical when treatment is attempted. What Frankel's rating the child fit into? Now, Frankel's has given four, that is stages, that is definitely negative, negative, positive, and definitely positive. Now, here the child is not cooperating and he is not sitting on the dental chair to get a dental treatment done, and he is behaving rudely. So, in this case, the child need to be treated under general anesthesia, and that comes under definitely negative, that is stage 1. Okay, so this is the option is A, that is 1, that is definitely negative. Now, the maximum increase in the number of S mutants. So, when we talk about the maximum increase in the number of S mutant, we think about window of infectivity, and this window of infectivity was given by Caulfield. Okay, was given by Caulfield, and the Caulfield has given two period of the window of infectivity. The first window of infectivity, when that is during the period of 7 to 31 months of the age, when the first primary teeth erupts. Okay, and by the set of by the age of 2 to 3 years, when the primary set of dentition completes, and then the second stage is from 6 to uh, 12 years, when the first permanent molar erupts, and to the age when the second molar erupt. So he says that the maximum colonization is seen in the second window of infectivity, and that is from the transition of primary to permanent dentition, that is between the age group of 6 to 12. Now, the sequence of primary teeth affected in children with a high caries susceptibility. Now, if you remember the sequence that I have given you in the chapter of dental caries, that is where we have talked about the early childhood caries, and I have told you that which teeth is affected first. So, if you see this options, the sequence of primary teeth affected in children with a high caries susceptibility, and we have discussed this in the chapter of early childhood caries, that is maxillary central incisor, maxillary lateral incisor, then maxillary first molar, maxillary canine, mandibular first molar, maxillary second molar, and then the mandibular second molar on the later stage. And when the mandibular incisors are involved, that means that it's a case of a rampant caries. Now, while placing the stainless steel crown on the primary first and the second molar, what sequence should be followed? Place the crown first on the primary first molar, then on the primary second molar. Place the crown first on the primary second molar, then on the primary first molar. Place the crown both on the teeth simultaneously, and both the teeth should never be crowned simultaneously. See, whenever we generally get the case, so this is my E and this is my D. So what I'll do is that I'll first place the crown on the primary second molar, followed by the placement on the primary first molar. The reason is that on the distal side we have the first permanent molar erupting. So we need to see that my distal margin of the stainless steel crown should not cover the unerupted first permanent molar path. Okay, if it covers the path of the unerupted first permanent molar, definitely the path of the first permanent molar get deflected. So you need to be very carefully that if you are placing the crown, first you place it onto the primary second molar, followed by the placement of the primary first molar, so that the crown should not extend much distally. Now, the objective fear in a child is derived from imagination, parents, obsessive peers, and or the past experience. Now, there are two types of fear. One is the objective fear, that is because of the past dental experience, and the next is the subjective fears, which is basically of the parental origin, where we basically heard in the family regarding the experience regarding their experience regarding the dental treatment or any medical health problem, and when the child visit to the dentist, he had that same imagination into his mind. So that is called a subjective fear. But here they are asking that the objective fear is mainly because of the previous past dental experience. So the correct answer for question number 4 is the past experience. Now, in a distal shoe space maintainer, what depth should be the guiding plate to go below the mesial marginal ridge of the unerupted first permanent molar? It should be 0.5, 1, 2 mm or 2.5 mm. The correct answer is it should extend 1 mm below the mesial marginal ridge of the unerupted first permanent molar. Now, which material is not used for pulpotomy? We have discussed regarding the different materials used for pulpotomy in the classification. So, laser, we use it for pulpotomy. MTA, we are using it for pulpotomy, that is in the regeneration. Then we have a ferric sulfate, we are also using in the preservation. Then the mesto paste. Now, this mesto paste is basically used for the pulpectomy procedure, not for pulpotomy. First window of infectivity is 7 to 31 months of the age. Next question is the self-inflicted injury is seen in which uh, syndrome? Now, in the starting of the lecture, we have discussed that the self-injurious habit is basically seen in the patients of Lichtenstein syndrome, and these are especially seen in the mentally challenged children or the children who have an intellectual disability where they cause an injury to himself or herself. Okay, so and that is seen in 10 to 20% of the children. So the correct answer is the Lichtenstein syndrome. Now, Hamlich maneuver in a child done for removing any foreign body that is causing any obstruction due to inhalational. So, in this, we basically give the abdominal thrust to the patient so that if the patient, you can say something has entered into the windpipe, so by giving the abdominal thrust, we basically bring that thing out of the oral cavity. So, that is called as the Hamlich maneuver where we do the abdominal thrusting. Now, which of these is an indication for the formocrystal pulpotomy? Now, whenever we do a pulpotomy, it is always see that the inflammation is confined to the coronal pulp, or there is an uncontrollable hemorrhage, or the inflammation extending to the radicular pulp, or there is a necrotic pulp. So, they are telling about the indications of the pulpotomy. Okay. So, I have told you in the indication part that if the inflammation is confined to the coronal pulp and the hemorrhage is controllable, then we do a pulpotomy. So the correct answer for this is that the inflammation is confined to the coronal pulp. Now, if there is a bleeding, that means that's after the you can say after we place a moist cotton pallet and still the blood is coming out. That means that the inflammation has extended to the radicular pulp. So in that case, I'll be doing a pulpectomy rather than doing a pulpotomy procedure. Now, pulpotomy comes under which level of prevention? It always comes pulpotomy, pulpectomy, or any extraction procedure followed by space maintainer always come under a tertiary level of prevention. Now, what is the reason for longer etching time required in the case of children? Less cooperation in the procedure, denser enamel in the case of children, Enamel is aprismatic and wavy in orientation, widely spaced enamel rods in oblique direction. So this is a thing that has been asked multiple times in the MCQs, okay, regarding that why etching is done more in the primary teeth compared to that of permanent teeth, and that is only because of the aprismatic enamel, that the enamel is more mineralized and it needs to be etched more. Next question is the sequence of teeth affected in the children with high caries susceptibility. Again, they are asking the same order that just now we have discussed. Now here they have mentioned few teeth. They have not mentioned the canines. Okay, they have only mentioned the incisors. So the first teeth is the maxillary incisors, maxillary molars, followed by mandibular molars, and the last is the mandibular incisors. So then the term said to be as a rampant caries. If the mandibular incisors are not involved, then we call it as early childhood caries. It's a preventive procedure, but for that, if you are doing an extraction of the teeth, okay, so that comes into the tertiary level of prevention. Now, a child behaves inappropriately during his dental visit. In response, the dentist sent the mother outside the operatory. Now, this kind of behavior management is termed as. Now, most of the students still did have a query regarding this question, that it should be a negative reinforcement or an omission. See, negative reinforcement, always remember students, we took an example while I am discussing the lecture with you. In negative reinforcement, we always do a selective selection of parents, or you can say selective elimination of the parent. Either the father or the mother will remain inside the operatory, okay. So we ask the parent, like suppose if you will able to handle the child when you are inside the operatory, or if you are able to see it if the child is cry, then if the mother says no, I'll not able to see, so then we say that okay, the mother should sit outside the operatory, the father will remain inside the operatory, okay. Why? Because the mother concern or the mother fear will be affecting the behavior of a child. So withdrawal of a unpleasant stimulus to increase the probability of the behavior. So we told mother to be outside the operatory and the father to be inside the operatory. So that is negative reinforcement. Omission is where you are sending the parents outside the operatory, that if you will not behave properly, I'll send the parents outside the operatory and I'll call them only once you behave properly. So that is called as omission or timeout. So the correct answer is omission. Now this question we have already discussed in the lecture, that is 12 primary and 12 permanent teeth is seen at what age in a child? Okay, so it is 11.5, 6.5, 8.5 and 13.5. I have told you the three transitional period in the mixed dentition: first transitional, inter-transitional and second transitional. So this is seen at the inter-transitional period, that is between the age group of 8.5 to 9 years, where you see a 12 primary and 12 permanent teeth, and it's a stagnant phase and no changes take place. Very common question, the brushing technique that is most commonly used in these children is a phones technique. A 5-year-old child has a multiple surface caries in the second deciduous molar. What is the treatment of child? Now, multiple surface caries means that is mesial, distal, occlusal surface involved, and we know that it's very difficult to uh, uh, put the restoration. There are chances that the restoration may break. So, in that case, you can place a stainless steel crown. Till what age a newborn is called as a neonate? It is 4 weeks. Okay, that is 1 month. Now, the non-pharmacological method of aversive behavior management in a child patient is tell show do, voice modulation, desensitization modeling, hand over mouth exercise. Now, they are asking about the aversive behavior management. Now, in the aversive behavior management, we have two things. One is the hand over mouth exercise, and the second is the physical restraints. So, it involves two things. That is, one is the hand over mouth exercise, which has a modification of Omar, that is hand over mouth, airway restricted, and the second is we have a physical restraint. So, the correct answer for this is hand over mouth exercise. Now, according to the latest recommendation, the recommended time for the etching of the primary teeth for the composite restoration is less than permanent teeth, same as permanent teeth, more than permanent teeth, and no etching required. Now, in the lecture also I have told you that earlier the concept says to be that the primary teeth requires more etching because of the aprismatic enamel, but now they have find that the etching doesn't basically change the, you can say, the bonding thing. Okay, that will not any in any means it will not affect the bonding of the on the primary or the permanent teeth. So if you increase the etching time, that will not help in any way in the bonding process. The effect will be the same. So there is no point in doing more etching in the primary or doing less etching in the permanent teeth. So they say that it should be same as that of the permanent teeth. Okay. And that is 15 to 30 seconds. Now the next question is, the gingival abscess is seen in the primary molars, most commonly drain on the facial aspect of the gingiva. Why it is draining on the facial aspect of the gingiva in the primary molar? It is because of the increased number of accessory canals located in the furcation area of a primary teeth, and whenever you see an IOP X-ray of a primary molar, you will see the radiolucency present in the furcation area, and the answer is increased porosity of the pulpal floor and the accessory canal that is draining into the interradicular area. Okay, it is not because of that the roots are flared or it is ribbon like or there is a thin dentin in the primary teeth. No, it is because of the increased number of accessory canals that are located in the furcation area. Now the age of the patient is 5-year old, and the lower second molar was found to be grossly carious. So if it's a grossly carious, then it cannot be saved. So you will extract the teeth followed by a distal shoe space maintainer, because the permanent first molar is unerupted. So it will help to guide the unerupted first permanent molar. So the correct answer is C. Now, the next question, in a 7-year-old child, the bilateral maxillary second primary molar are absent. The space maintainer best indicated here is. Now, see here the age is 7-year-old. The tooth involved is a maxillary teeth, and that is second deciduous molar are absent. So, by the age of 7, the first permanent molar will be erupted. So, the best space maintainer that I'll go with is by making a band onto the first permanent molar, and that will be my Nas palatal. Because the Nas palatal is given when there is a bilateral loss, whereas transpalatal is given when there is a unilateral loss. And both the space maintainer are given for the maxillary arch. Now, in rampant caries, the mandibular incisors are usually spared. This is because of the inherently resistant structure of the incisors. They are continuous bathhead in the saliva produced by the submandibular and the sublingual glands, and the position of the tongue covers the lingual surface. They are clean due to the action of the tongue. They are protected by the lower lip. Now, the most common reason that why the mandibular incisors are spared, that is because of the increased salivary production, okay, and that is because of the submandibular and the sublingual glands that are present. Second most common reason is the tongue is present on the floor of the mouth, so the patient will have that cleansing action always. So the primary reason, we need to talk about the primary reason, and that is because of the increased salivary production. So the correct answer in this question is B. And now a 2-year-old child comes to the clinic with a history of fall from the bed. 12 hours back on the examination of the upper central incisors are intruded into the alveolar bone. What will you do? Now if you see, the time period is only 12 hours and the central incisors are intruded. So in the intrusive luxation, we have studied that in 90 to 95% of the cases, the primary incisor re-erupts on its own within a period of 2 to 6 months. So in that case, nothing to worry and just wait and watch. So no surgical repositioning, no orthodontic repositioning, just wait and watch. In adults, we never see a radiolucency in the furcation area. We generally see a radiolucency at the apical area or at the lateral area because of the presence of the accessory canals that are present at the apical or at the lateral area. If we see the radiolucency in the furcation area of a permanent teeth, that means that there is some problem with the floor. Either the floor is fractured or it is totally gone or it's decayed, and that is why the prognosis is said to be poor when it we see a radiolucency in the furcation area of a permanent teeth. Now, the radiograph of a 6-year-old child shows the presence of a supernumerary teeth present between the roots of the developing maxillary central incisor. The teeth are asymptomatic. How you will manage? Okay. Now, the radiograph of the patient, which is showing, is age is 6 years, okay, and there is a presence of supernumerary teeth, okay. Now whenever we see a mesiodens or any supernumerary teeth, the first and the foremost thing that we need to go is just extract it, because that will cause the hindrance in the path of the eruption of the permanent incisors, okay. So never wait and watch, extract the mesiodens carefully without causing the trauma to the adjacent tooth buds. Okay, no need of waiting it, because that will act as an obstruction in the you can say eruption of the incisors, or you can say that can cause the malocclusion in the future when the permanent teeth erupts, and then we need to go with a fixed orthodontic treatment. So once you have diagnosed and you find it a presence of a mesiodens, then go for the extraction. Now, if the IQ is less than 69, we called the child as a child having an intellectual disability. So here they are asking that if the IQ level is less than 50, it is classified as mentally challenged, mentally retarded. I have told you, but now we are not using a word mentally retarded. We are using the word intellectual disability. Now the next question is, what is Babinski reflex? Now in the Babinski reflex, I have told you that we basically check the reflex of the toe, and that is done by moving onto their plantar surface from the heel to the toe area, and once you move from the heel to the toe area, you will see the flexion of toe. So this flexion of toe is called as a Babinski reflex, okay, and we have already discussed in the lecture. So they have just asking the definition of the Babinski reflex. So the correct answer is D, that is hyperflexion of the digit of the toes, and the adduction of the helix when the sole of the foot is stroke from the outer surface to the base of the digits and then along the ball of the foot. A patient with a history of trauma shows the fracture of the enamel pulp dentine of tooth 5-2, and what is the Ellis classification? Now, I have told you in the lecture also that any injury related to a primary teeth, and if they are asking for the classification and in terms of the Ellis and Davy, so all the injuries related to the primary teeth, okay, whether it may be intrusive luxation, extrusive luxation, concussion, subluxation, or any enamel fracture or enamel dentine or enamel dentine and pulp, anything that is there in relation to a primary teeth, that will comes under Ellis class 9 only, which is the traumatic injuries related to primary teeth. That's all. Now, in a village school of a child, a tooth is avulsed. What is the best medium to transport the avulsed tooth in a rural area? Now, if you're living in a rural area, you don't have that solution, physiological solutions like Hank's balance salt solution. Okay, so what you'll do is the best physiological solution is to take the teeth in a milk, because it is said that if you keep the averse tooth in a milk in the first 20 minutes of the avulsion, then you can basically preserve the viability of the periodontal ligament cells. Okay, because the milk consists of the constituents such as the amino acids, the carbohydrates, that plays an important role in preserving the viability of the periodontal ligament cells. Now the next question is, which milestone of a child coincides with the eruption of the first primary molar? Okay. So first milestone is making 3-4 word sentence, standing without support, bowel control, focusing on light. Okay. Now I have given you the list of the different uh, milestones. So there are different milestones that are mentioned in the books, but I have jot down the important milestones. That is, when does the child stands without support, when does the child stands with support, or when the child basically sits with support, or sits without support, when does the head become stable, when does the head doesn't become stable. So we have already discussed this thing. Okay, now standing without support is the correct answer. Why? Because we know that the first primary molar generally erupts by the age of 15 months. Okay, by the age of 15 months. Okay, so and by 12 to 15 months only, we generally see that the child stands without support. Okay, whereas between 10 to 12 months, the child stand with support. Now the next question is, the maximum gain in the height in the boys occurs during which year of life? Now it is said that the maximum gain in the height in the boys is generally seen in the first year of the life, and the maximum growth spurt generally in boys is seen in the age group of till 16 years. Till 16 years. Now the next question is, a child starts to hold the head stable at what age? Now please just I think this is mention it wrong. It is not 6 to 7 months. The correct answer is that the child start to hold head stable at what age? It head stable by the age of 3 to 4 months. By the age of 3 to 4 months. So please correct in your PDF file. It is 3 to 4 months. Now one student is asking regarding the difference between the plantar reflex and the Babinski reflex. See, Babinski reflex, I have told you regarding that when you move it from the heel to the toe area, there is a flexion of the toe, that but the flexion of the toe is upward. But in the plantar reflex, you will see the flexion of the toe is downward. Okay, so that is the difference mainly between the plantar and the Babinski reflex. Now, a mother brings a 9-year-old child with a pain in the right lower teeth. The mother gives a history that the child suffered multiple episodes of cold and fever in the recent past. On examination, the lower right first molar was found to have proximal caries. Okay, what is the first line of investigation? Okay, now the patient is definitely having a pain in the right lower teeth, okay, and he also having the episodes of cold and fever. So it is not always necessary that the patient is having a cold and fever only because of the toothache. Okay, there may be a patient may be suffering from a viral infection. So if the patient comes to you, the first and the foremost thing that you need to do is, so the option they have given is that you take a radiograph or the electric pulse testing or thermal testing or prepare a test cavity. See, these electric pulse testing and thermal testing are specially done in the cases of the traumatic injuries. So the most and the common diagnosis that we always do in every patient is always take a radiograph. So the correct answer is take an IOPA radiograph. A self-correcting anomaly in a 10-year-old child is, so we have discussed about the development of occlusion, the list of the self-correcting anomaly that is in the pre-dentate, primary dentition, mixed dentition and the permanent dentition. So then when they are talking about the 10-year-old child, that means something related to a self-correcting anomaly in the mixed dentition. Okay, so this anterior crossbite, bucco version of mandibular first molar or anterior open bite, these are not the self-correcting anomalies that you will see in the 10-year-old child. Basically, you will see a flaring of incisors, okay, at a 10-year-old child, and this flaring of incisors resulting into a midline diastema, and that is called as a ugly duckling stage or a broadband phenomena that gets corrected on its own, okay. Once the canine gets erupted into the oral cavity, this space generally get closed up. Now, which of the following is not a function of the crib? Establish a suction force on the anterior segment, make the habit unpleasant for the child, distribute pressure to the posterior teeth, act as a reminder for the child. See, they are asking that which is not a function of crib. So crib we are giving in the patients who are having a habit of thumb sucking or a tongue thrusting. Okay, depending upon if the patient is having a thumb sucking, then we can reduce the length of the crib. If the patient is having a tongue thrusting, then we can increase the length of the crib. But they are asking what is the purpose of giving a crib. Okay, so they are here in this option. They are asking that which is basically not the purpose of a crib or not the function of a crib. So grip does not establish any sort of suction on the anterior segment. Yes, it makes the habit unpleasant for the child, definitely. It distributes the pressure to the posterior teeth because the child will not able to develop the suction against the palate, and it acts as a reminder appliance. So we call it as a reminder therapy. Now, the sedation can be used to advantage in children for a management of anxious and apprehensive patients, for a better quality of dental procedure, can be used for in patients with underlying medical disorders. See, sedation is only specially applied for the kids who are anxious or who are apprehensive. Okay, if the patients are having any medical disorder or uh, uh, any systemic illness, then definitely we avoid the use of sedation. We have already discussed the ASA classification that is given by American Society of Anesthesiologists. So they clearly states that ASA 1 is a category who is fit for sedation, and that is a healthy patient. Okay. Whereas the patients who are having a mild or severe systemic disease are not to be treated unless and until by taking a consent from the physician. Now, next question is a patient age is 5 years, 4 months. The child has a retrusive chin with a reduced lower facial height. On intraoral examination, full cusp distal molar relationship is seen. Okay, that means the patient is having a distal molar relationship. So we have a flush terminal plane, mesial step, and distal step. So flush terminal plane transform into class 1 or class 3. Then mesial step transforms into class 1 and distal step transforms into class 2 molar relationship. So is seen in the cephaloparometric reveals a normal SNA but a reduced SNB. What should be the line of treatment? We should go with a Frankel's appliance. Okay, that is the Frankel 2 appliance that is given in the patients who are having a class 2 type of malocclusion, or a twin block. Okay, or we need to review at 6 years, or we need to give a bionator. Now these Frankel's, twin block and bionator are generally the myofunctional appliances. So do we really give the myofunctional appliances at an early age? It is no. Okay, so the correct answer is that we'll review at the age of 6 years, that is once the first permanent molar gets erupted into the oral cavity, because still the patient is having a distal molar relationship, and we need to see that this distal molar relationship transform into class 1, class 2 or class 3, whichever the molar relationship is, and depending upon that we'll decide that we need to give a which type of appliance. Okay, whether we need to go with a Frankel's myofunctional or a twin block appliance. So it's a very early call to give any myofunctional appliance. The next question is the patient age is 3-year old and the child has a lateral luxation injury to his upper central incisor. The tooth is not mobile and does not interfere in occlusion. And what should be done? Now see here they have clearly mentioned that the injury, that is the patient comes to you, is a lateral luxation of a primary teeth at the age of 3 years, and I have told you that if it is not causing any interference in the occlusion, I have told you in the treatment plan that we have discussed in the lecture that if it is not causing any sort of interference in the occlusion, just wait and watch. Okay, don't try to bring it back to its original position, then try to do the splinting. Okay, never ever. Just wait and watch. Okay. A child suffers from a trauma which causes the lateral luxation of the primary central incisor. The incisor is not occlusion and does not cause interference. What should be done? The incisor should be allowed for passive and spontaneous repositioning, be repositioned and splinted, reduce the opposing tooth, reduce both the affected and the opposing. See, if it is in the case of a severe lateral luxation, we generally say that okay, you extract the teeth. In the cases where there is a mild interference in the occlusion, we do the grinding. But if it is not causing any interference in the occlusion, then we always say that wait and watch in the case of the lateral luxation of the primary teeth. So for question number 158, the correct answer is A. The next question is a 3-year and 7-month old child with a history of traumatic intrusion of 5-1. The IOP reveals foreshortening. The treatment is, now I have told you that whenever we take a radiograph of a primary teeth, we always need to confirm in the cases of intrusive luxation that whether that intrusion has caused a damage to the permanent tooth bud or not. So if the image appears shortened compared to the contralateral teeth, that means that the tooth is displaced labally. But if the tooth appears uh, widen or elongated compared to the contralateral image, I am talking about radiographically. If it appears elongated, then it means that the apex is not clearly visible and it has caused a damage to the permanent tooth bud. But here they are saying that the image is something foreshortening. That means that the tooth is displaced labally. So in this case, the tooth will re-erupt on its own. So we just wait and watch. Now the next question is they are asking that what is true about a knee to knee position when applied to child management, all except. So out of this condition which is not true about the knee to knee position, that it is a practical method for babies up to 18 months. Yes, we use that knee to knee position. Operator secures the child hands while mother steadies the child head. No, it is wrong. Okay, the operator always basically make the headrest into his lap. Okay, whereas the legs are into the lap of the parents whenever the operator does the treatment. Accompanied with the glove finger and plastic sleeve pen light or torch. Yes. Can we use at home for brushing of teeth and infant? Yes. So the correct option in this is B, which is not a true statement for knee to knee position. Now the next question is the retraining approach in a pediatric patient, all are true except avoidance, de-emphasis, substitution, distraction, discrimination. Now these are some of also the non-pharmacological behavior management. Now what is this retraining? Okay, uh, retraining is basically a technique which is done in the patients who have a previous bad dental experience. Okay, so you need to retrain that child again because he had that uh, images stored into his mind, and you need to bring him out of that images, and you need to just feel, make him feel and make him discriminated that the treatment that you were approached earlier will not be the same every time. So don't get generalized, don't do the generalization of the treatment. Okay, you will help him how to discriminate between the treatment which you got earlier and now what you are getting. Okay, whereas De-emphasis and substitution, I have told you that they are the examples of negative reinforcement, and I have told you that is the withdrawal of the unpleasant stimulus to increase the probability of the behavior. For an example, you're using the erotor and the child is not liking the noise of the erotor, so you start using the excavator, hand excavator. So that is called as substitution. Okay. See, if the intrusion is palatally, then we'll go for the extraction of a primary tooth, because we don't want any damage to the permanent tooth bud. Now, in a stainless steel crown on a primary molar with overhanging margins, gingival plane and inflammation occurs. So, why generally the um, gingival plane and the inflammation occurs around the stainless steel crown? The main reason is because of the plaque accumulation, and that is because of the poor oral hygiene. Okay. Now the next question is, on a primary first molar, the caries occurs most commonly on which surface? So on a primary first molar, the caries generally occurs on the occlusal patent fissures only. Okay, that is the first surface to be, you can say, affected on a primary first molar. So whenever we are giving any drug to a child, okay, during the any procedure like pulpectomy or pulpotomy, so they are asking that what is the main criteria that you assess? It's the age, it's the nature of the drug, it's the intensity of the pain, or what? So we always go by the weight of the child. Okay, so we always measure the weight of the child, and according to the body weight, we basically calculate the dosage of drug, and that is the most commonly method employed in a day-to-day routine dental practice or a pediatric dental practice. So what is the definition of the autistic child? Yes, a child who is having a difficulty in the communication and has an emotional problem is called as a autistic child. A 7-year-old child comes to your clinic with ulcers with indurated margins in the oral cavity and fever with crusting of lips. The probable treatment plan is prescribe the broad spectrum antibiotic and mouthwash, symptomatic treatment and observation, clean the mouth with a gentle mouthwash, none of the above. Okay. So according to the symptoms that you are seeing, that the patient has ulcers, indurated margins in the oral cavity, and has fever. So you'll give a symptomatic treatment and just recall the patient for the review and the follow up. Okay. Don't immediately prescribe the broad spectrum antibiotics, mouthwash. Okay. So just give the symptomatic treatment and just recall the patient and just check that what is the probable cause of the lesions. Now, premature synostosis of coronal sutures along with the basal sutures shows which of the following feature. Now, what do you mean by this synostosis? Synostosis is basically, you can see the fusion of two or three bones together. Okay, so here they are talking about the fusion of the sutures of the skull. Okay, and accordingly they are asking you that which type of the type of head the child will have. Now this term, that is brachy, oxy, trigo, scapho, basically denotes the shape of the head or the shape of the skull. Now brachy is when the child has a broad and short head. Okay, when the child has a broad and short head. Oxycephaly, you will see that the child has a pointed head. Trigo means that whenever you see that, you will see that there is there are sutures that are present in the skull, and that is called as the metopic suture. Okay, so what happen is that whenever there is a premature closure of this metopic suture take place, what will happen is that the shape of the head generally transform into in a form of a triangle. Okay, so a triangular shape of the head is generally seen, and that is called as trigonocephaly. And what is scaphocephaly? Scaphocephaly is where you see the child is having a narrow and a long skull. And this generally, all these things generally take place when there is an improper fusion of sutures. So here they are asking that when there is a fusion of the coronal and the basal suture, which type of the shape of the head the child will have. It will have a pointed head, that is called as oxycephaly. Symptomatic treatment is that for the ulcers you generally prescribe some gels, okay, to the patients rather than writing the systemic antibiotics, and give him a painkiller if it is required, then only take it. Okay, any mouthwash, generally like benzodiazepine mouthwashes, which basically helps the child to eat the food, so he can take just 15 minutes before the meal. So these are some of the symptomatic treatment that you can give to the child. Now see, for question number 118, I will not be discussing right now because still there is a little bit of confusion. Okay, now in the MCQ books, most of the MCQ books I have gone through, and in that the answer is written only the Carpenter syndrome. But what the condition that they have given, according to me, it should be an Apert syndrome. So first I'll clarify this question, okay, and I'll just report in the group. So I'll not be discussing this question because still it's a controversial thing. So question number 118, I'll just confirm with you first, and then only I'll discuss with you. Okay, that is 118. A 6-year-old patient has a blue dome shaped swelling in the posterior mandibular region. What will be the treatment plan? See, in the mandibular teeth, if you see the posterior mandibular teeth, you'll see that at the age of 6 years the first permanent molar erupts. Okay, and when the first permanent molar erupts, sometimes there is a process that is called as eruption gingivitis or an eruption hematoma that is generally seen. Okay, so we just need to reassure the patient, just wait. If the patient is having any pain or something, you can give the gel to the patient. So we just say that reassure the patient without any treatment. Don't do any marsupialization or excising the gingival tissue. Will not going with any sort of procedure because the first permanent molar is erupting in that particular area. Now the pulpal infection in a primary mandibular posterior teeth is manifested on the radiograph in the area. We have already discussed that in the primary mandibular teeth you will see a radiolucency in the furcation area because of the increased number of accessory canals. An 8-year-old child with a large front frony teeth having jagged margins seek consultation. What is the treatment plan? Now, as a pediatric dentist, this is the thing that most oftenly in my day-to-day routine practice. Most of the time, the parents are coming that the teeth are looking bigger. Okay, so will they grow more, or what is this jagged margins that I can see on the incisal edge? So I always tell the parent that no need to worry. Right now, the teeth have erupted into the oral cavity. The teeth never grow in size. The facial height will increase, the width of the face will increase, and the body proportion will also increase. Once that increase, the teeth will appear smaller, and these margins will get smoothened up because these are some of the mamelons that are present on the incisal edges. So just assure the patient and send them back. No treatment is required. So the answer is C. Now, what is the concentration of sodium hypochlorite in the Curie solve? It is 0.5 to 1%. So, what is Curie solve? It's a chemomechanical caries removal, which is basically an agent which basically used to soften the dental caries that can be removed with the help of spoon excavator rather than we use an eroder to drill that caries part. Okay, there are other chemomechanical caries removal agent by the name of Papa Care or Carie Care. Okay. Now the ferric sulfate in the pulpotomy is applied for how much seconds? We have already discussed in the lecture. It is applied for a duration of 10 to 15 seconds. Now the first sign of formocrystal pulpotomy is pain, internal resorption, pulp obliteration or the change in the color of the tooth. Now what they are talking about? They are talking about that what is the biggest disadvantage of the pulpotomy. The biggest disadvantage of the pulpotomy or the you can say the main failure that you will see in the case of pulpotomy is the internal resorption. Is internal resorption. Now, the gingivitis in children most commonly occurs due to the local irritants, vitamin deficiency, herpes infection, or malocclusion. See, the gingivitis that is in the children is most commonly occur due to the poor oral hygiene, and the plaque accumulation generally results into the gingivitis. So we always tell the kids that do a proper brushing, do apply a Phones technique, and it is only because of the local irritants. Now, the toothbrush of a child differs from that of an adult in soft bristles with smaller head size, soft bristles, big head with small handle, size of the head of the toothbrush, soft bristles, head, big handle. It is always differs because of the size of the head of the toothbrush. Because the depth of the vestibule in the case of the children are very small compared to that of the adults. So we always need to use a smaller head size of the toothbrush. Now, what is the concentration of the fluoride ion in the APF gel applied topically? The concentration of the fluoride that is applied in the APF gel is 1.23%. It is 1.23%. The pH of MTA during the, you can say it is during the time of the mixing, it is around 10, but by the time it sets, the pH set to be 12.5. Now, an HIV positive child comes to your clinic for the extraction of his carious mandibular first molar. What should be your approach for the treatment of this child? ELISA test and consult with the physician, referring the child to the HIV clinic, order for the CD4 count and consult with the physician, advise TB test and consult with the physician. Now, this you can say for an HIV patient, we always see the CD4 count, okay, and this CD4 count in a normal healthy person it comes to be between 500 to 1500. But in a case of a HIV patient, if it is less than 200, then definitely the patient is having a low immune system, and in that case we are avoiding the dental treatment, and we always have a consult with the physician and then we do the treatment. So this CD4 is basically the cluster differentiation 4 test. Okay, and these are basically the glycoproteins that are present on the immune cells like T helper cells or like the monocyte cells. Okay, so we need to check that what is the level. If the level is coming down, definitely the immune level of the patient is also coming down. So if it is less than 200, then definitely we need to be send the patient to the physician immediately. So the correct answer in this question is C. So this is regarding the all the questions that has been asked till date in the previous year papers, whether it may be AIPG, NEET or the PGI papers. So please go through the video once again. If you have any doubt, you can ask in the group and let us know. Regarding that one question, I'll let you know once I'll be confirmed with the answer whether it's a Carpenter syndrome or it's an Apert syndrome. But what I'm feeling, it's an Apert syndrome, but in most of the MCQ they have mentioned regarding the Carpenter syndrome. So first I'll confirm and then I'll let you know in the group. Okay, so thank you so much students. And now one student is asking to please explain the retraining approach. Retraining approach, as the word says, retraining, it is done in the patients who are having a previous bad dental experience. So you need to make them calm and composed, because see, whenever they are coming from a bad dental experience and they're coming to your clinic, your work becomes difficult. You need to retrain the child. So that retraining process is something that you need to make them discriminate that okay, what all things that has been done in that clinic will not be done here. You need to be calm, composed and relaxed. You cannot generalize the type of the dental treatment. So you need to make him accustomed to your dental atmosphere, and you need to make that things that has been gone into his mind, uh, you need to remove that all that fearful stimuli, so that he can accept the dental treatment. So that is basically called as a retraining approach. See, generally, for any luxation injury, whether it may be concussion, subluxation, any injury, the inspection is always done in a period of 1 month, then 3, then 6, and then 9 months, and so on. So this is how we basically do the uh, checkup of the patient. And for the vitality, when we are talking about the vitality in the case of the traumatic injuries, we always say that if the patient vitality need to be checked, it should be always assessed after 14 days of the traumatic injury, because the tooth is in a state of shock. So the tooth may give a false response. So you can call the patient after 14 days and just check the vitality. See the bristles, we basically not are focusing on that whether the bristles are soft or hard. We are always focusing on the head of the toothbrush, and we always say that use a medium type of the bristles, neither using a soft nor the hard. And the head of the brush is very important, because that can cause an injury to the patient, and will the patient will not do the brushing properly if the head is large. So the size of the head of the toothbrush is very very important because of the depth of the vestibule. Okay, so thank you so much, students, and all the best for your exams. Uh, and just go through the all the subjects one and revise it, because it's the revision time. Solve as many as MCQs possible, and all the best for your exams.